Welcome to our first of the year, first of 2026 Q&A session. We really wanted to host this session tonight on behalf of Conceive Health and on behalf of Evolve Egg Freeze to really give people a chance to get answers to many of the questions that we see swirling around out there, popping up in chats, popping up in forums, and to allow our community, allow the online community to really ask some experts the real talk. So tonight we have Dr. Tracy Malone joining us, and she is a naturopathic doctor as well as the co-founder of Conceive Health. Conceive Health is a unique clinic and it specializes in natural and preventative approaches to reproductive health. So egg health, sperm health, reproductive health, fertility, infertility, the whole gambit. Dr. Malone is our naturopath expert there. And then on the other side of your screen, you'll see Dr. Sony Sierra, and Dr. Sierra is the medical director at Evolve. She has been the medical director at Evolve since we launched as the first and only egg freezing clinic in Canada. And she also is past president of CFAS, and still sits on some of the committees at CFAS, which is the Canadian Fertility and Andrology Society. Both of our doctors sit on the panel here tonight. So a little bit of admin here. At the bottom of your screen, you'll see a Q&A box. So please feel free to enter any questions you have, anything that comes across your mind. Nothing's too big, nothing's too small. If you want your question, well, all the questions remain anonymous anyways, but you also can click off anonymous so that we can't even see the name coming through. But we will pose the question to our speaker panel here, and they will both have a chance to answer for you. At the end of the session, we also are recording this here, so we also can provide you with the video. So feel free to start entering some questions in the Q&A, and we will get started. I actually have one first question that has already come in. And so both of you, Tracy and Sony, feel free to field whatever you feel you want to step in on from your unique perspective. So someone here is saying, which matters more, egg quality or egg quantity? I have been told I have PCOS and that I have a lot of eggs. And that is what you get to start you off here, ladies.
So
I don't know who wants to start.
first, Tracy. So I think they both matter. I think when we think about egg freezing success, we think that both your age at which time you do the egg freezing, which reflects sort of egg quality, is important, as is the number of eggs you get. So I would say they're equally important. With PCOS, you're probably asking because you know you're going to have a lot of eggs because you've got a lot of follicles, but you're concerned about the quality of those eggs. Even though people with PCOS do have lots of eggs, they tend to think, well, your fertility is protected, like your AMH is really high. You can sort of leave egg freezing until later. But the reality is age still is super important. So it is the most important predictor of egg quality. So I think that that's important to know. And then the other things, PCOS has a whole metabolic part that can also affect egg quality. So there's extremes of body weight, there's being overweight, BMI over 30 with PCOS. And then there's the other phenotype, which is lean PCOS. So those sort of extremes of body weight can also impact egg quality as well as metabolic health. And then I'll let Tracy carry from there.
Yeah. So that's a great segue because I think sometimes women with polycystic ovarian syndrome or polycystic ovaries potentially can have an inflated level of confidence in how many eggs they may have. And while we can often see them on the ultrasound and count them on the ultrasound, and give you an antral follicle count, it doesn't necessarily mean that all of those oocytes or eggs would respond to stimulation and mature when we're looking to retrieve them on an egg freezing cycle. And that, as Sony reflected on, does have a lot to do with metabolic health. And so when you have extremes of body weight, we measure it in BMI or body mass index, whether it's, higher end over the scale of 30 BMI points or under 19, you can absolutely see maturation issues with those eggs. And so that would be more of a quality versus a quantity factor. And so in the clinic, if we do see that, we're looking to help that patient with lifestyle metrics, making sure that they have all the macronutrients they need in appropriate quantities and micronutrients in the form of supplements, and a well-rounded nutrient-dense diet so that their oocytes would be able to have the building blocks to be sensitive enough to the signaling to mature on a timeline.
Thank you. Yeah. And Sony, do you want to speak? I know Tracy spoke a little about the maturation. I know patients are often confused about, or sometimes confused about all these eggs, and they bubble up, and like why they all need to be mature. If you're just taking them out anyways, does it matter what stage of maturation they're at when they are being retrieved? If someone is going through an IVF or an egg freezing cycle, what's the importance with the maturation?
So, mature egg is the only type of egg that we can freeze. It's the only kind that will sustain the sort of freeze thaw process. So, in order for egg freezing or fertilization, it's important that the eggs be mature. And maturation in egg is the last sort of really important stage of genetic development before an egg is released and can be fertilized or frozen. And it's a really important step, and it does reflect, again, egg quality, because eggs that are not good quality or have not made enough estrogen, have not responded to stimulation as well as other ones might not be mature. Sometimes we do, and sorry, might not be mature because they weren't genetically normal in the first place, or perhaps they needed more time. When we trigger for egg freezing, we try to balance the trigger so that we have a good number of big size follicles that are most likely mature and a good number of sort of ones that are just about to be mature. But inevitably, in any cycle, you're going to have some that are not mature. In the lab, we can sometimes culture those overnight to promote maturity, and then we can freeze or fertilize the next day. But it is really important, and we can only do egg freezing on mature eggs.
Mm-hmm.
And is that something, how does a patient know if they have gone through a cycle, if the eggs that are taken out are mature or not? Is that something that the lab tells them right away, or how at Evolve do we let patients know that?
So the day that you have your egg freezing procedure, you'll know how many eggs we collected, but we don't look at them under the microscope or freeze them at that particular time. So before you leave the clinic, you'll know how many eggs we retrieved. But then the next morning, you'll get a call from the nurse to let you know how many of those were mature and how many froze.
Mm-hmm.
Great, thank you. In looking at, there's a few things talking here about some food habits. So one of the questions is, are there any foods or habits you often suggest that people limit when they're thinking about their egg health?
I'll take that one. So yeah, when we're talking about foods to limit, when you're looking at improving egg quality, I think you're looking at limiting, ultra processed foods. I think is one of the things that you don't really want to have as a main staple in your diet. So, we talk about carbohydrates, for example. It'd probably be the most obvious take on this is that here in North America, they refer to our diet as the SAD diet, so the standard American diet. And that does kind of trickle into Canada as well. And, you have folks that are relying on their primary fuel source, carbohydrates, coming from ultra processed, I would call them beige carbs. And they don't really have a lot of nutrients, micronutrients, or, phytonutrients and antioxidants in them naturally. Whereas if you choose like single ingredient, I call them single ingredient carbohydrate, that makes it real simple. It's like an apple or berries or like a sweet potato. Those are all carbohydrates too, but they have a vastly different micronutrient spectrum. So getting rid of, the ultra processed carbohydrates, and then the ultra processed fats, right? You have to remember that like our cell membranes are made up of, the fat that we eat. And if we're constantly consuming, trans fats and adulterated fats that our body don't really recognize as foods, those are going to have an impact on, our metabolism, inflammation, as well as, gamete quality, egg and sperm health. Yeah. Mm-hmm. Mm-hmm. Those would be the big ones. And then I think my constant, I sound like a broken record, is eat more protein, 100%, that I'm chasing people constantly. My friends, my patients, we under consume protein. And so the amino acids are these building blocks that really your metabolism and your eggs use as, primary building blocks for their metabolism. And if we're under consuming protein as a whole, it can be ultra problematic for that. Mm-hmm. Both for.
Can you
Mm-hmm.
speak a little to a little more to that when we're thinking of maybe a typical egg freezing patient who is in her, let's say, early to mid 30s, works long days, lives on her own, has a lot going on, maybe tries to eat more of a vegetarian type diet, maybe an incomplete vegetarian type diet, might eat out a little on the weekend. Can you talk a little bit about how we can fit protein into the day?
Yeah, this is a common theme. I just had a few patients just as you described. So ultra go-getters, medical researchers and sort of, PhD students that are constantly working and constantly doing things. So their schedules are overflowing. And there's a lot of misinformation. So I see a lot of these women doing things like intermittent fasting, right? And they'll call it intermittent fasting, and they'll just like hightail it out of the house on a double shot of espresso and not eat until 1 o'clock in the afternoon. And it creates a.
Yeah, that's not a normal diet.
I mean, that was my whole undergrad, right? So, I mean, it is a phase of life, but you can't you can't sustain yourself like that long term. It'll affect your central nervous system. It'll affect your energy levels. It'll affect your muscle mass. It'll affect your insulin sensitivity, your mood, and ultimately your egg quality. So, what I would say, there's a few kind of, rules of engagement, I would say, to getting it across the line. And my first goal usually is like try to hit about 90 to 100 grams of protein a day. We can get more specific on that if we're looking at metabolic factors. But to do that, to hit 100 grams a day, you really need to eat within an hour of waking. Your first meal needs to contain 30 or 40 grams of protein right off the bat. And then 30 grams with each meal, right? So first of all, like if you're doing an intermittent fast and your feeding window is only 6 to 8 hours, there's very low chance you're going to get that 100 grams of protein in that 8-hour window when you're working. It's like zero chance. So in fact, a lot of intermittent fasters are just kind of under consuming in caloric deficit. And so in sports medicine, we call that the REDS. That's a relative energy deficiency syndrome. And, it makes people more prone to, poor recovery and, injury and things like that. And so when I talk about, egg freezing or fertility treatment, we kind of treat it almost like as a sporting event, in a sense that you have to get yourself ready, fueled. Your oocytes need to know that they have all the building blocks that they need to run their sort of energy house, which is their mitochondrial house. And that's like key for egg quality. And I think that really does start with getting, that sort of like just staple 100 grams of protein throughout the day. So
right.
I'll endorse women to use like things like whey protein isolates. That's there's no shame in that for sure. And arguably lots of people wouldn't hit that 100 grams if they didn't have that. So I call it a functional food. So that's an easy one for the no breakfast eaters, right? That like fly out the door.
We're getting a protein shake in us, or a Greek yogurt with something in it.
my
Some
favorite.
eggs for our eggs, maybe.
Eggs for your eggs. And so, the most nutrient dense would be steak and eggs, right? Obviously. And then like pick a single ingredient carbohydrate to go with that. Your easiest is, Greek yogurt with a scoop of whey protein stirred into it, topped with berries. That's a 40-gram protein bomb that you didn't turn your stove on for. And then, if you have a 5 a.m. practice or something like that going on, then, you can throw a clear protein with some creatine into a shaker bottle, grab an apple, and you're out the door. No stove turned on either, right? So there's ways to do it. It just
Yeah.
depends on how much time you might have on the given day.
There's another question that kind of ties into that, talking a little bit about supplements. So, is diet enough, or when you're in this fertile window, are there fertility supplements that are worth taking?
I mean, I would say yes to that. And so, even with the best diet, right? When we're talking about fertility supplements, we're talking about sort of pharmaceutical strength or therapeutic strength dosages that will make impact on the metabolic, you know, uh, the metabolism of the egg and the maturation. So, like coenzyme Q10 is a really good example of this. I had a patient a while ago ask me if they could get all the CoQ10 from their diet. And I said, well, you could, but to get 600 milligrams of CoQ10, which is a fairly standard dose for egg freezers or for IVF patients, you'd have to eat like a 12-pound beef heart every day, right? So like who's actually going to be doing that? So it's it's possible. Is it realistic? Maybe not, right? So in my realm and in my patient's demographic, convenience equals compliance, right? And so if we need to keep a habit for a period of time, we have to make it convenient enough that it's attainable for them, that they can do it in mix it in with their daily life that they have right now. So this is where I think that the supplements, things like CoQ10 and omega-3s and vitamin D and things like that can really help to move your metabolic needle. I call them lifestyle levers, is how I refer to them. And so you can really sort of press into that mitochondrial circuitry by providing them with optimal fuel sources and therapeutic doses. And that's where I think the supplements come in. Mm-hmm.
Back to more a little talk on cycles and eggs. Someone is asking if they can freeze their eggs if they have an irregular cycle.
Yeah, I guess I can take that one, and that definitely there's different reasons for having irregular cycles. The most common one is something like PCOS, where you're not ovulating on the typical 14-day schedule. You might be ovulating a little bit later, and therefore you're having irregular cycles. Um, as we get older, also we can have experience shorter cycles. That's a little bit more concerning. I would definitely still consider egg freezing if you're in a good age range. And that's something that we manipulate completely when we're doing egg freezing, whether your cycles are shorter or longer. The way we administer medications is to sort of mimic the hormones that your brain makes to send to your ovaries to get them to start making eggs that will eventually ovulate. However, we add in another medication to prevent that happening until we see that the majority of them have a good chance of being mature. So we can manipulate when you would naturally ovulate or not ovulate, and therefore are able to freeze eggs even in irregular cycles.
Mm-hmm. Mm-hmm.
And in talking again about ovulation here, there is a question about improving ovulation in PCOS when there is a low LH level.
How to improve with a low LH level. So
Mm-hmm.
typically, when you have PCOS, your LH level is a bit higher, your androgen levels are a little bit higher. Um, so we can manipulate that again by giving medications to help overcome those initial hormone imbalances, something like letrozole or Clomid. I also use metformin. There's some decent evidence that metformin is helpful in terms of regulating androgen profile as well as different aspects of the egg metabolism that are off in women who have PCOS. Um, I think also in addition to the medication that we could use to sort of manipulate ovulation, there's also the whole lifestyle that Tracy just went into with PCOS. So making sure you're as healthy as you can be in terms of diet, exercise, and lifestyle, which can also improve and regulate androgens and LH levels that might have a good impact on ovulation. I think it's really important. Used to do PCO clinic at the hospital, Women's College Hospital. So lots of young people who weren't ready to necessarily conceive. But it's a really important message that people with PCOS that have irregular cycles or irregular LH levels, diet and exercise are so important because of the long-term risk of metabolic syndrome. So it's important to have good habits in place that will serve you well immediately in terms of regulating ovulation, but in the long term, avoiding complications like diabetes and hypertension and things like that.
Yeah, I would add on to that, especially that example that you gave, Sony, of seeing the younger patients in the PCO clinic that maybe they're not ready to conceive right now, but the ovulatory cycle is still important for them to go through
Mhm.
that hormonal cascade as young women. And I think people get overwhelmed with lifestyle metrics, feeling like they have to be completely in the normal range before they'll see any level of improvement. But it actually, has been shown that just 5%, a 5% weight shift can actually
Mhm.
re-trigger
Mhm.
spontaneous ovulation in anovulatory PCOS patients. And so,
Yeah.
5%, you're talking about, somewhere between 5 to 10 pounds. It's not an
Yeah.
astronomical amount. And if we do it correctly with the correct, I would call them again, lifestyle levers. So weightlifting and protein, you can change your muscle mass just slightly enough to trigger that
Mhm.
metabolic sensitivity that will help with regulating ovulation. So it doesn't have to be perfect to be effective, is what
Right.
that would be the message I would try to drive
Yeah.
home.
Yeah.
Yeah.
It can
And I
be
Yeah.
think, I think we can, I mean, I do work with Conceive and go back and forth in terms of people looking to optimize their lifestyle, but sometimes it's just the simplest advice. So exercising 3 times a week, at least 30 minutes to break a sweat, avoiding most things that are white, like white rice, white potato, white bread, and nothing in a package. Like that's sort of the simplest
basic.
guideline that you give young people. And 80% you follow those rules, and 20%, of course, like with
Mhm.
Christmas. I mean,
Yes.
it's
80/20.
impossible to avoid white flour and white sugar
Mhm.
and shortbread, but
Yeah. Have to
most of the
survive.
time it's okay. Yeah.
This next question actually ties into a lot of what you were both speaking about and the metformin and the sugar. There's a question, does blood sugar or insulin regulation affect egg quality? So we talked a little bit about how it affects PCOS and the cycle, but if you can talk about how it affects egg quality.
Definitely has an impact. So elevated blood sugar, uncontrolled diabetes, it's very, very detrimental to egg health, and subsequent pregnancy as well. So it is something to avoid and have looked at before you start egg freezing. We typically wouldn't start an elective egg freezing cycle if blood sugars were abnormally high, or if a hemoglobin A1C, which kind of tracks sugar over time, was elevated as well. Um, Again, part of what we do at Evolve is sort of fertility education and also egg freezing. So understanding the impact on your eggs and your fertility and your health is important and will be addressed if that's something that's seen on initial take-in.
Yeah. Yeah. I would second that. Yeah. I think that the glucose insulin interface is something that I see so frequently in the clinic in PCOS patients and otherwise. Like they don't necessarily have to have PCOS to have augmented glucose disposal, is what we would call it.
Mhm.
And I think it's more obvious in PCOS. I think they're more vulnerable in a sense to elevated insulin, and that then triggering elevated androgenic production at the level of the ovary. And, this can affect their sensitivity to stimulation and things like that. So, it's so incredibly valuable to have that patient in what I would call like a sensitive metabolic space, be like adjunctively as they're moving towards an egg retrieval, because it will impact your experience with the process for sure. And again, it doesn't have to be perfect before you proceed, but putting those metrics in place while the cohort is maturing during that 1 to 2 months prior to the retrieval can be dramatically impactful for how well you're going to like respond and the outcomes and how many mature oocytes you're going to get, right? So it's definitely worth the time to kind of check in on those balances before proceeding.
The next question that someone is asking is, does keto style diet affect egg health or stimulation? When you're answering, can you tie in what you just kind of touched on that a lot of people might not know about that 90-day, that importance of the 90 days and the egg cycle, if you will?
Yeah. So women are born with all the eggs we'll ever have. And so fun fact, if you're ever carrying a female baby, you're also carrying, all of your future grandchildren, right? Which I find is kind of a mind-blowing fact, right? So all female babies are born with all of the eggs that we'll ever have. They kind of lie dormant in the ovaries as primordial follicles. And after puberty, each month, a group of them come forward and start to mature. And it takes 3 months. It's called folliculogenesis, right? The follicle is like a big beach ball filled with follicular fluid, and the egg is bobbing around inside. So the follicle is almost like an incubator while the egg's kind of maturing along that folliculogenic pathway. And after 3 months, those are the follicles that we can see on your day 3 ultrasound. So that 3-month period preceding when they're going to get their cycle start is critical. The hormones, including insulin and estrogen and androgens, the nutrients and bioavailability of amino acids, social toxins, circadian patterning, all of those things would impact the viability of the eggs that are maturing during that 3-month phase, including your diet. So back to the question you're asking, does the ketogenic diet, right? How does that impact? So ketogenic diets by definition are carbohydrate void or close to. And what that happens to do is it shunts your major sort of energy pathway from glucose into burning fat for fuel. And that can be really inflammatory and really oxidative, right? So burning fat as a primary fuel source can increase your oxidative stress during a time when we're trying to decrease your oxidative stress while your follicular cohort is maturing. So in my opinion, it's really not advantageous to put yourself onto a carbohydrate void diet and then start burning fat as fuel, right? So you're asking the mitochondria inside your oocytes to like gear down and actually start burning a different type of fuel source for its major sort of energy production. I think that is not a great idea for fertility patients. We do need some level of carbohydrate, right? And using carbohydrates, the right ones that don't spike your glucose levels, that have fiber and have other types of, phytochemicals and micronutrients in them are really advantageous. And you can eat those healthfully without spiking your glucose and spiking your insulin levels if you get rid of the white stuff, as Sony said, right? If you're not relying on white, processed carbohydrates, you're not going to have that glucose spike as much. So for me, keto diets are a no, in my opinion, for preconception phase and during IVF cycle. I don't think it's a good idea, even in a diabetic patient.
I agree.
Yeah.
The next question is, quite specific, but I'll give a general overview, and I'll actually take this moment right now to let everyone on the call know that, or everyone on the chat here know that we will be sending out a follow-up email, and Conceive Health offers short 15-minute kind of clarity calls to learn a little bit more about what's going on in their clinic. And so the individual who's written this question, if you want a little more clarity, it might be great to book a call, because this is a little bit more specific, but maybe if you want to give kind of an overview, if you can, either of you, it is someone who's been very healthy. They eat around 130 grams of protein a day, track their macros, strength train 3 to 4 times a week, and run or jog a few times a week. They're 41 and they didn't have a great response with their first round of IVF. They made 4 embryos. The situation states the egg health made them non-visible. What are your thoughts and insights as you prepare for the next round of IVF? So again, like I said, we can't always get super specific with patients because there's a lot going on, but just an overall general thought as you see that kind of come across here.
So I guess I can start. It sounds like you are doing all the right things that are in your control. Um, and you are 41, and I think we have to look from a big picture perspective. On average, or most people, I think it's 1.6 cycles to take home a baby. I think I froze. Uh-oh.
Yes, we can still hear you though.
You can hear me, okay. 1.6 cycles to take home a baby. So the fact that at 41 you made 4 embryos is actually really good. The fact that their egg health made them non-viable, I'm going to assume that means that you did genetic testing and they were all genetically abnormal. That unfortunately can happen when we're doing IVF at any age. We're not doing IVF to fix an egg problem or necessarily change egg quality. IVF itself is a numbers game to gather as many eggs as we possibly can and then retrieve them. We use different stimulation protocols in an effort to get a maximum response, so we get the maximum number of eggs that then have a good chance with laboratory techniques of making embryos. But we can't, with IVF, change the genetics of your egg. And at 41, that's your biggest risk, or your biggest sort of bump in your road. So you have to look at it in terms of, like I said, you're doing everything you can. And how I would say is that at 41, because you're so healthy, you had a great IVF cycle and you made 4 embryos. Most people at 41 don't. But it's just random luck that the embryos you made weren't genetically normal. And you will have a conversation with your doctor about trying again. Is it worthwhile to roll the dice, do this again, hope for a better outcome? But I think you should feel good about that result in terms of the number of embryos, despite your age.
Mm. Yeah, I would second what Sony said. Sounds like you really have all the lifestyle factors on point, everything that she listed out. And at 41, I think it's about, persisting until you get genetically normal embryos. Usually, like, patients are still making embryos, then there's a potential, right? In my opinion. So you have to have a conversation with your REI and decide if another cycle is going to be advantageous for you, to see if we could come up with genetically normal embryos, because I think it's probably an age factor.
Mm-hmm.
Yeah, thank you.
Mm-hmm.
If progesterone is low, can it be improved naturally before egg freezing?
So if progesterone is low, I'm assuming it's been tested in the luteal phase, which is post-ovulation. And if you are ovulating, you will inevitably have a rise in your progesterone. So I'm assuming there's ovulation issues in someone like that, and a little bit of cycle irregularity. Can it be improved naturally? Well, if there is an ovulatory issue, yes, based on everything that Tracy and I spoke about. But beyond natural progesterone sources, I'm gonna bunt it to Tracy because I don't know.
Yeah. So again, what Sony said, if you're ovulating, then you're going to get a rise, and normally in the luteal phase, we're looking for the progesterone to be kind of like over over 30 units, post ovulation or so. But realistically, if she's not producing adequate progesterone in the luteal phase, I often consider that as an oocyte quality issue, because it is in fact the egg itself that will make the corpus luteum that then makes the progesterone after it's ovulated. So in my eyes, if the progesterone is lower end, I do treat that patient for egg quality issues usually, and focus on egg health, egg maturation, and making sure you're getting a good, healthy dominant follicle that's being released. And that should correlate with higher levels of progesterone. And if it's not, then we take progesterone post ovulation in order to facilitate pregnancy, etc. Although that wouldn't necessarily be applicable to an egg freezing patient.
Mm-hmm.
You're going to be freezing them, getting pregnant at that time. Right.
We have a few more in here. Can supplements like inositol, or berberine support blood sugar?
Yes. Yeah. So Sony mentioned earlier metformin, which, is a super commonly used primary drug for PCO, polycystic ovaries and polycystic ovarian syndrome. It does help to regulate glucose interface. Metformin is actually originally derived from French lilac, which is a plant, right? And so berberine is also a plant, and it has a very, very, very similar mechanism of action than metformin does. So I would almost place them as identical mechanisms. Very useful for helping to regulate ovulation and improve insulin sensitivity. Myo-inositol is a line item. It is a B vitamin derivative, typically given in a 4-gram dose. It's a powdered agent, and its claim to fame is that it helps to sensitize the insulin receptor, so you become a bit more sensitive to your own insulin that you're making, which can help to regulate ovulation and can help to regulate egg maturation and egg quality via those mechanisms. Yeah. So 2 different agents working at the same sort of outcome, but different mechanisms of action. And of course, both of those types of treatments are always best when paired with diet and lifestyle. And so diet and exercise, right? So metformin and berberine work best when paired with exercise and a low glycemic diet and a high protein diet, right? So it sounds like
it does all tie back to to the beginning example. Yeah. There's just a few more questions here. 2 of them kind of come in together and speak about low AMH. So one person is specific talking about they're over 35 and they're looking to improve their AMH or help treat their AMH, any advice for diet, lifestyle, supplements, and someone else along the same lines, deficient in vitamin D, deficient in a few things, and they're wondering if that's affecting their egg quality and AMH. If you can just speak a little bit to AMH and the effect of supplements or lifestyle on that.
Mm-hmm.
So,
go ahead.
Do you want to start, Tracy? I was just going to say AMH is sort of made by the granulosa cells that surround your follicles, and follicles are little pools of fluid that contain immature eggs. They're microscopic until you start a cycle, and then there's a handful that come up and we can see called your antral follicle count. And AMH is not a diagnosis or a marker of whether you can conceive or not. It's more, we use it as a predictor of how you would respond to stimulation. So how would you fare in an IVF cycle? Being over 35 and having a low AMH, it depends how much older than 35 you are, if there's reason to be concerned. But unfortunately, I'm not aware of any particular medication or procedure or infusion or lifestyle factor that's going to actually change your AMH level. The day that women are born, we have all the eggs that we're ever going to have, and the rate with which that changes, it sort of starts at the onset of your cycles, and it sort of progressively goes down from there. And the rate that it changes depends a lot on genetics. Of course, there's obvious things like smoking, toxin exposure, certain systemic um, issues, medications, etc. But once that decline starts, there's no way to reverse it. Um, and so there's not much you can do to change your AMH, but there's a lot we can do to help you conceive, regardless of where your AMH is. I don't know, Tracy, if you have anything to add about specific supplements.
Yeah, like just what Sony said, like we use the AMH as more of a barometer of a predictor of how you might respond to treatment, and it can give some level of context to maybe how many eggs might show up on your day 3. But usually it's steady, I would say. Like I don't necessarily see patients taking egg quality supplements and then have a giant bump in their AMH. That doesn't really happen. But what you may see is you may very well see the upper end of their antral follicle count show up, right? More consistently, I think is what we're going for. And so each month when we go in and look on your day 3 to see how many eggs are coming to the plate to run the race for dominant follicle that month, that's called your antral follicle count. And although your AMH may stay the same, you will see variation in how many follicles show up on your day 3. And so, it's a range. And so what I would say, the egg quality and the lifestyle metrics will have her often showing up at the top end of her range for the antral follicle count, even though the AMH is more static. That's what I would say about that. And they're all what I'm talking about with supplements. It's the ones we've discussed before, things like coenzyme Q10, NMN, carnitine, NAC, etc. The second part of the question was, do things like vitamin D deficiency impact egg quality? I think, Tavia.
An AMH, yeah, it said.
I haven't seen direct correlationship between vitamin D and AMH. Sony, I don't know if you have. I've never read a paper on that, so I would say no to that. But quality and receptivity. So, when you have ovulated and you're looking to implant a fertilized egg or an embryo that has been created, vitamin D matters very much, right? Not only in the creation of the embryo, but also in the endometrial receptivity, right? And the interface between the embryo and the endometrium for implantation. There seems to be quite a lot of interface with vitamin D there.
You spoke on with the quality on NAC. Someone else was asking about PQQ.
Yeah.
And if that is something that you recommend, or if there's evidence on that improving egg quality.
Yeah. It's a favorite. We've used a coenzyme Q10 with PQQ in it in the clinic for many years now. PQQ is a separate antioxidant, and it's one of the only agents that we know of that will help to regenerate new mitochondria, right? Which is different than fueling the ones you have. So oftentimes we'll combine PQQ, usually at a dose of 20 to 40 milligrams. It doesn't have to be very high in comparison to CoQ10, which is dosed at about 600. And we use it quite a bit in the clinic as an added agent. N-acetylcysteine, NAC. It's an amino acid. It is a precursor to our most potent antioxidant that we make in our liver, glutathione. And when you take in NAC in therapeutic doses, you can improve the amount of glutathione that you're making. So it's an endogenous antioxidant that we make on our own. And there's a good amount of research that shows that that's highly, highly compatible with fertility treatment and egg quality.
The last kind of full question here is related to an egg retrieval and egg freezing. When is it safe to resume normal exercise after an egg retrieval?
So when you're having an egg retrieval, it's a surgical procedure, needle guided, ultrasound guided needle aspiration on ovaries that have been well stimulated. So when you start an egg stimulation cycle, your ovaries are probably the size of prunes, um, plums, I should say, like 3 centimeters, 3 to 4 centimeters. And then at the end of it, they're probably like the size of grapefruits. So they're very big. They're hanging on sort of like grapes on a vine. And so they will feel extremely bulky, you'll feel bloated. And because they're like hanging like grapes on a vine, there's always a risk they could twist. And so we do recommend after an egg retrieval, even though the retrieval's been done and we've removed follicles, the ovaries still maintain that size and that sort of grapes on the vine appearance. So we typically say no strenuous physical activity, like no jumping around. You probably wouldn't feel like doing that immediately after the egg retrieval. And I typically say at least a week. And then just depending on how you did, like how many eggs you got, if you're at risk of hyperstimulation, it depends on how you feel. When you feel no longer bulky, no longer sore, that's probably a good sign that you can resume activity. But going into an retrieval cycle, not knowing how you're going to respond, I would say bank on about 7 days after an egg retrieval to resume your normal typical activity.
Mhm. Yeah, I would second that. I usually just say wait till your next period
Yeah.
because I feel like girlies are doing crazy stuff at the gym these days. So I like, you don't know what someone's when they say, I want to exercise. I'm like, but
And what
what?
is normal? What's their
Yeah,
normal? Is their normal going for
are
a
you
walk or are they
CrossFitting
in high
and muscle
rocks?
upping and swinging around a bar, or what are you doing? Like people are doing wild stuff. So I usually just cap it and say until you get your next day one, just walking, please.
Mhm.
Well,
Mhm.
thank you very much, ladies.